Thanks very much, Hitesh. I'm going to start sharing if I may. Can you see that? There we go.
Yes.
Yep, good?
We got you, Alistair.
That's fine.
Great. Well, welcome everyone. Thank you very much for joining us. My job is to tell you what happens when Walant doesn't necessarily go as well as you thought it might. I've got plenty of experience of that, and also how to set up your practice so that you don't get into trouble in the first place. So learning objectives. So you've heard about why from Don and Costas, and shortly to have Amir as well. What I want to talk about is what to use to keep yourself out of trouble, where to do it to feel relaxed and not anxious, when to do it, on what patients, etc., and which patients are the best ones to do it on, certainly the best ones to do it on first of all, and then potentially what to move on to afterwards. So as we have discussed, lignocaine with adrenaline, 1%, 1 in 200,000. This is our standard xylocaine with adrenaline in the UK. In Canada, for example, they have 1 in 100,000. Personally, I don't think it makes any difference at all. Costas uses 1 in 120,000. It's not going to make any difference to your hemostasis. You may need to leave the local in for a little bit longer before you start your operation to get adequate hemostasis. But even this, I really rarely wait more than 15-20 minutes before doing the operation. You can add sodium bicarbonate. It certainly does make it less painful. Xylocaine with adrenaline is acidic and therefore will be painful if you inject it. Just to minimize that, it can help to put some sodium bicarbonate in if you've got it and it's easily available. I must say the vast majority of the time I don't. I use the other principles that Don has taught us to reduce the pain of the injection. There is some quite interesting physiology behind the bicarbonate. So ionized and non-ionized forms of local anesthetic do different things and act in different ways within the tissues in which you inject it. So ideally, if you have your pH at the same value as the pKa value for the local anesthetic, and you can look all this up, and Henderson-Hasselbalch equations and all sorts of fantastic biochemistry that you learned at med school but haven't really thought about since. But theoretically, if your pH of the tissues, of the lignocaine is near the pKa value, it will have faster onset and work for longer as well. So the learning points: use 1% local anesthetic, lignocaine with adrenaline. We know it works. Every time I've tried to use something different, it's gone wrong. Every time I've used bupivacaine with adrenaline, just bupivacaine with adrenaline, or if I've used prilocaine, which I've used once, because the entire hospital ran out of 1% lignocaine with adrenaline. I actually ended up, the guy was particularly sensitive to prilocaine, and he got methemoglobinemia and had to go to intensive care overnight, and I had a complaint on my hands, quite, well, not unreasonably. So there are problems if you don't stick to the script. So the one take-home message I want you to take away from these 20 minutes that I'm talking is use 1% local with adrenaline and just put lots of it in. You can put bupivacaine in at the end, you can put bupivacaine in at the start. It does hurt more if you do that, but again, why not put it in? If we know that it works, use the 1% lignocaine at the beginning, do your plenty of time, nice and relaxed, and then at the end, give them 15 hours of pain relief, and you're injecting it into no more pain. That's certainly what I do. Every time I've tried to use something else, it just hasn't worked as well. 1% lignocaine with adrenaline works every single time. If you're doing a simple block instead of a ring block, 2 mils of 1% lignocaine with adrenaline in the front of the finger works. It numbs that finger and it never has let me down. So absolutely, just stick with that to start with. Have some spare. Sometimes it depends on the complexity of your operation. If you're just doing a carpal tunnel, then between 7 and 10 mils is absolutely sufficient. But if you're doing scapholunate ligament reconstruction like I did recently, there was just one bit around the radial styloid that clearly wasn't quite covered with the volume that I used, but I had 15 mils spare, so we just put that in and absolutely no trouble at all. So there's all sorts of things you can do when Don's doing big tendon transfers and things like that, or if you're starting. You may not quite get one little corner of the dissection, but again, if you've got 5 or 10 mils, 15 mils, you just pop it in and the patients remember the rest of the operation. They don't tend to remember that bit. And as Don's already said, and Costas has alluded to, you use volume. We have to get away from the old principles, the old 5 or 10 mils along the wound edges at the end of the operation. That's old hat. If you've got 50 mils of 1% lignocaine with adrenaline to use, then use it. You're not going to give anybody compartment syndrome. So if I'm doing a distal radius and I'm doing it under regional anesthesia because that's the easiest thing that we have in my hospital, or if it's particularly complex, then at the end of the case, I'll close, or actually usually before I close, I'll put 50, 60, 70 mils of very dilute local anesthetic with some long acting in there, or mostly long acting. And I've never had a single problem with compartment syndrome. So its volume is absolutely key. So where and when? Where is a problem? I definitely have a problem with wear because I operate electively 3 floors below where my patients come into the hospital. So that my patients come up to F level and they sit in the waiting room in F level in the admissions unit, and I'm operating on C level. So I can't just nip up, pop some local in and then nip down again in between cases. It just simply doesn't work. So even if you're operating in main theatres, in a minor ops room, or even in the office sometimes, or in the outpatient clinic, you do have to think about your setup. You've got to think about, where are my patients coming to? What kit do I need to do the injections and have a trolley or something available? So when Costas sets up his day, he has X amount of milliliters of local anesthetic for the day, and he makes it up at the beginning. I think that's very sensible advice. I use xylocaine with adrenaline vials, 20 ml vials, so I will get them out of the fridge in the morning or even sometimes the night before. And in fact, I carry local around in my work bag, so it's all nice and warm before I inject. So it doesn't matter where you're injecting, it doesn't particularly matter where you're operating, but you do need to think about the relationship of the two and how you set up your day. So as I said here, proper preparation prevents poor performance. Where are my patients coming to? Do they need monitoring? I personally don't use any monitoring for any patients after I put local anesthetic in. I'm just going to reiterate Costas's point that always have patients lying down. If you try and cut corners and you do them sitting, one of them will faint and then the nurses get terribly upset. The patient doesn't particularly like it either. And it delays you having to get to theatre. So just lie the patient down on a couch, put the local in, and then the patient can sit up at their leisure. Planning your list. I work in a major trauma centre. I always have an anaesthetist allocated to my list. So for me, the cost benefit of local anaesthetic is irrelevant because my anaesthetist is being paid whether he's working or not. So if I do a Walant case, he's just sitting on his bum having coffee. And that's fine, you know, full respect to them. But if you're going to do a Walant case, plan your list such that maybe you do your Walant case first, and then you have another patient in the anesthetic room having a regional anesthetic put in. But then if you've got a Walant case third, you can always inject the first and the third cases at the beginning, do your first case, by which time the regional anesthetic will be ready. Then you can do your third case, and you can piggyback your list. So planning your list is absolutely crucial. So it doesn't matter if you've got an anaesthetist there, use them and get the patients in so that your list is efficient. And that's where Walant definitely comes into its own, because you can do whatever you like on that day. You can have a whole day of Walant, which would be lovely, but it's really quite hard work. You can have a mixture of local anesthetic and regional anesthetic. General anesthetics tend to just get in the way, frankly. It doesn't take very long to put a patient to sleep, but it does take a long time for that patient to go off to the recovery area. And for them, they always feel much worse when they've had sedation. So just like Don, I don't use any sedation at all on my patients. I talk to them, I chat to them, I create a very relaxed environment. I've never had a patient, so this is supposed to be about cautionary tales, and I was thinking, have I ever had a patient who didn't enjoy being under local? And I've been racking my brains and I cannot think of a single one. You can have a good laugh with them. I give a lecture which is how tweeting during your surgery can improve your outcome. And what I mean by that is that if your patient's got their mobile phone, and I let all of them bring their mobile phones into theatre, I warn the staff beforehand, and none of the staff mind either. And patients absolutely love taking pictures, taking selfies in theatre. And what it does is it engages them. And if you engage your patient, and you engage the theatre staff, and you engage your trainees, everybody has a nicer day. Everybody just gets on, you're relaxed, they're in control. And this is something Don's taught us, and we've all realized, is that if the patient is in control and they're helping doing their surgery, then everybody's happy and everybody gets a better result. And certainly even the scapholunate ligament reconstruction I did recently that I was saying about, I was really anxious before that because they're quite hard operations. They're not always as successful as we hope they would be. And my patient was just brilliant. He said at the beginning, he said, you know, Ali, I completely trust you. I'm going to help you with this. So we know we're going to come off the table with a good result. And he actually put me at ease, which was amazing and really, really nice to see. So injecting, the evidence says that for 1 in 100,000 adrenaline, it's 23 minutes to maximum hemostasis in the skin. I totally agree, and I think a minimum of 20 minutes is absolutely fine. However, if you time, and I've done this in theatre, if you time how long it takes for a patient to get from the ward into the, so you've injected them on the ward, for example, how long it takes for them to get from the ward to theatre, and then you prep the patient, and then you drape the patient, and everybody's messing around getting their bits and bobs ready. For anything other than a carpal tunnel, it's 20 minutes in theatre before you're even knife to skin. So actually, it's very simple. Sometimes you can get the patients down into the anaesthetic room, and then you can put the injection in, go off and scrub, get your scrub nurse to start doing their bits and bobs, get the x-ray in, whatever you need to do. And by the time you're done, the local anaesthetic's working. And then 10 minutes into the operation, you're at 30 minutes. So I know Jason Wong up in Manchester, he injects in the anaesthetic room very often, and the patients 5-10 minutes into the operation, they're at maximum hemostasis, and it's not usually a problem. So, who to operate on? This is probably the biggest challenge in some ways, because most patients come to a surgeon and have that tradition. It may not be the same in Canada because they're more used to it, but certainly in the UK, if you come to a hand surgeon and you want an operation and you get put onto the waiting list, your surgeon will say, fine, we'll do pre-assessment and you'll have to come in and have that. And then you'll have to stop these medications and that medications. And then suddenly we're turning around to them and saying, oh, you don't need to come and have pre-assessment. You don't need to stop your warfarin, because we never do. You don't need to stop this, that, and the other drug. And you'll be awake in theatre and you'll be helping me. And that's really, really different. Don't underestimate how patients go, whoa, really, doc? And we go, yeah, it's absolutely fine. So what you have to do is you have to sell it. And you have to sell it to the patient that this is the way I do these operations. So cubital tunnels now, I haven't done a GA or an RA cubital tunnel for about 3 years, because the patient just lies there with their hand behind their head and you do the operation and it's easy peasy. Now, there are a few cautionary tales about who, because if you talk about your patients, you also have to talk about your colleagues. And I've been very lucky at Southampton. We have a fantastic bunch of hand surgeons and we all get on very well. And they've been very supportive of me bringing Walant into the department. It's not always the case, and it sometimes can be tricky. So patients tend to be the easy sell. You'd say, right, this is how I do it. You're going to help me during the case. And that's really powerful because they say, oh, okay, great. So you tell me when you want me to do something. And we do. And we talk to them and we chat to them and we find out a bit more about them. And then you say, right, this is your time to shine. Bend your finger very slowly. And they usually do things too quickly because they think everything's fine. So they, I did have a 17-year-old Polish chap, and I was doing two tendon in each finger, FDS, FDP, zone 2. Took me a while. And after 2 hours, I just heard this snoring in the background. And I jabbed him and I said, oi, wake up. And he woke up with a start and then went, ugh, and then ruptured everything. But clearly, by rupturing all my repairs, they weren't good enough. So we did them again, and it all went well. But do make sure your patient's comfortable. And quite often they will actually have a little sleep. This is a really important point. Walant is different. Walant is fundamentally different from what your patient is expecting. And if you just think that they can come to theatre and they'll be fine, you're probably kidding yourself. Because it's so different, the more information, the better. So get some information sheets, and we're busy. Actually, I've got some to put up on the website, actually. So keep your eyes on that as well. And information sheets just explaining a little bit about how the day is going to go, how the local anesthetics go in, because everybody's worried about needles, and just really overemphasize the fact that you're going to use small needles. Honestly, I'd be really upset if anybody used an orange or a blue needle on me. The little 27 gauge are perfectly good enough, and they work and they don't hurt. Just please, please, please get away from hurting patients. I'm totally with Don on that, and he completely changed my practice when I saw him doing that. So small needles, lots of volume, take your time, relax the patient, and use information sheets so that they know what to expect. I bang on about education and engagement the whole time with Walant, because I think we as surgeons are obsessed with the surgery, and there's so much more to Walant and the benefits of Walant than just the operation. Yes, you can do flexor tendons better. Yes, you can do soft tissue intraoperative active movements, but I am really passionate about how Walant can change your relationship with your patients, and how if you have a better relationship with your patient and they trust you, you can get a better result no matter whether you're an average surgeon or an amazing surgeon. If your patient trusts you, they will get a better result. There is absolutely no question in my mind that that is the case. Your colleagues, however, are a different matter. This is very different. So my advice to you would be to go on safety. Plenty of evidence, as Costas alluded to, plenty of evidence that adrenaline is not an issue anymore, which is why Don has referred to it as the adrenaline myth, because it is a myth. There is no literature saying that you should not use adrenaline in fingers. Full stop, end of story, no debate. Don't even look it up. It's not an issue. Efficiency. If you piggyback your local and regional cases, you will get more done. If you have 2 rooms where you can inject, you can piggyback your injections, you will get more done. If you have less people in the system, so no anaesthetist, no ODP, 1 or 2 people in theatre, you will get more done. The more complicated you make any system in any walk of life, the more inefficiencies there are and the more opportunities there are for this not to go right. Walant is the most efficient local anaesthetic technique you can use in theatres, full stop. And patients love it. If you want to convince your colleagues that this is something that you should try, or that they should try, or that you need to start doing because you want to try it, just go, okay, right, well, let's do a pilot study and we'll take patient satisfaction scores, we'll do all the outcomes, and the outcomes will be the same, if not slightly better than your previous operations. We'll look at the cost of it, and then suddenly you've got all this information. Oh, actually, my patients really, really like being awake. I quite like them being awake because I get to know them a bit better. They're really happy. And suddenly your colleagues have nothing to go on to criticize you or stop you doing it, and your management don't have anything to stop you doing it. So that would certainly be my objection. I get a couple of emails a week saying, I really want to start, but I need monitoring for my patients. You go, okay, fine, we'll do 20 monitored and do 20 unmonitored and see if there's any difference. Then you can say to your managers, well, there's no difference, so therefore I'm not monitoring. And I'm saving you money, by the way, because you don't need a nurse to sit with that patient. So in summary, go back to old orthopedic principles, do what works for you. Use 1% local anesthetic with adrenaline. Absolutely, every time. Put the bupivacaine in at the end, that's certainly what I do. But if it works for you and you want to use something different and you are familiar with the nuances of that local anesthetic, then use what works for you. Same applies to operating. If you're happy in a minor ops theatre, great. If you're happy in main theatre, great. Nobody's going to tell you not to do that. All we're going to do is put the evidence out there and you can make your own decisions. Ideally for Walant, you do need to be quite close, not 3 floors away as I am. I'm trying to change that, but it's not. It's very difficult to find a different operating theatre. Plan your lists, take control, don't let your secretary do it. Get in there, sort your lists out. I'm going to do this case under Walant, I'm going to do that case under regional, I'm going to do that case under a GA. And while they're doing the GA, I'm going to do another local case in between. Make sure you plan and be charming, because at the end of the day, if you're empathetic and you have emotional intelligence as a surgeon, which I know is a bit difficult for some, just look after your patients, respect them, go gentle on the local, and they will respond. They will find you charming. They will help you when you need help. They're never going to put a complaint in against you if you are empathetic and emotionally intelligent. Okay? But the other thing, just in brackets there, keep good notes and audit, because this is so different for a lot of people still. It may not be in Canada and America, but in the UK, there's still a lot of people who are not comfortable with Walant. Keep good notes, keep good audit, make sure you can back yourself. Okay. Thank you very much, everyone.
Thank you, Ali. That was a fantastic presentation. And what was really impressive was the way you care for your patients and your colleagues as well. Thank you. It was lovely listening to you. And
thank you very much.